Dr. Ashok said. And what is also very important to see the OCT images from 6 months. And today I will also share with you some of our 6-month follow-up. We have 10 cases with a 6 months OCT follow-up, and there was no single free, not endothelialized scaffold in all cases. So it is very reassuring that we have a very favorable outcome so far in these patients. So this is a case with, again, with a very good endothelization, with a complete coverage of the scaffold after 6 months. So the final conclusion of MERES-1 first-in-man trial was that there was no major adverse cardiac events or scaffold thrombosis up to 6 months, with a very low late lumen loss of 0.15. So the second trial that already finished enrollment is MERES-1 Extent. PI is Dr. Ajay from Brazil. And so as I mentioned, from 8 sites, we have 64 randomized subjects. In all cases, we perform OCT during implantation, and at least in our subsets, we are doing OCT in all cases after 6 months, and we are planning to do OCT after 2 years in all cases. So I will share with you for now just 1 or 2 cases with a MERES-1. This was a 63-year-old female with a proximal LAD with a significant lesion of the proximal LAD. And pretty significant plaque burden in this particular patient in the proximal LAD. So it's very important to use the same PSP strategy we are pretty aware we used with absorb implantation. And again, with this technology, we strongly recommend this a very important PSP strategy. So we did a predilation with 3015 and implanted MERES 3.5 by 19 at 16 atmosphere, and this is the angiographic outcome, perfect angiographic outcome. And you will see how it's OCT after implantation. So this is OCT after implantation. Some not well opposed scaffold struts. So we did a high pressure post dilation, and this is OCT at the end, and this is the final result. So this final angiographic result in this particular patient. This angiographic result at a 6-month follow-up. And here is a 6-month follow-up OCT. You can clearly see that all scaffold struts are endothelized. And one more patient I will share with you for now. It's a young 50-year-old male with a very significant LAD and with some septal branch involved in this particular case. So it's a predilation and 3.5 by 24. And this is a result. So we did some post dilation. And after here, you will see that we lost our big septal branch. This was a final result. So this is an OCT, and you can agree that this OCT is not a perfect result after this procedure. So definitely because, but maybe it was due to the fact that it was a very significant plaque burden and significant lesion. So this is the OCT after procedure. And to be honest, we are very much excited to see how patient will perform, not just clinically, but also at the follow-up. So here is a 6-month follow-up in this particular patient. Big septal branch is open now after 6 months, and this is the OCT. So if you compare these OCT images, so this is after procedure, and this is OCT after 6 months. So it's a pretty reassuring and perfect, I will say perfect re-endothelization of the scaffold. So for now, we can conclude that in clinical practice, bioresorbable scaffold could restore the vessel to a more natural state, enabling natural vascular function. MERES 100 bioresorbable scaffold technology represents an emerging concept resulting in biomechanical properties comparable to other bioresorbable scaffolds and moving toward conventional metallic drug-eluting stents. So far, to be honest, there is no significant difference with a second-generation drug-eluting stent and performance in a routine clinical practice. But of course, we have to accept that we need the further trials and a longer-term follow-up. And it will definitely differentiate these very promising technologies. So these encouraging results provide the basis for further studies using a wider range of lengths and sizes, because nowadays we have only 19 and 24 length in 3.0 and 3.5 millimeters. But we know that MERS 100 is available in a large size varieties in terms of a profile, of course, and length. And next stent with a 64 patients clinical trial, which completed recruitment in multiple sites in Europe, Asia, South and South America. And we are looking forward for a randomized trial against the second generation metallic drug-eluting stent, which is hopefully planned for Q2 in 2017. So what is the new arrival from Meril? What we are actually promised to receive very soon. So it is a tapered bioresorbable scaffold, the same as BioMime Morph. I'm sure some of you have some experience with BioMime Morph, which tapered design from proximal to distal size. And this is a similar concept. And MERS 100 as a sirolimus eluting scaffold will definitely will be an added value to this very important development. And of course, there is another opportunity for embolic protection scaffold. Hopefully, this device will be useful in more thrombus-containing lesions, but this is just a future development that we are looking forward, and so far we do not have any clinical experience. However, we do hope that this device could find some role in a thrombus-containing lesion. But at the end, I would like to remind you that we were very much enthusiastic with Absorb in the beginning, but definitely Absorb did not meet our expectations. Nowadays, we are really very excited with this second generation, with the upcoming technology of bioresorbable scaffold, particularly with the thin scaffold Strat 100, MERS 100, and we hope that all of the unmet needs with the first generation will be significantly overcome with the second generation of scaffold technology. Thank you very much for your attention. Questions in regard to this introductory talk? Yes?
May I request panel to please be on a dais, please? Dr. Jaspal Arneja, Dr. Jurbek, Dr. Balgate, Dr. Babinaswile, Dr. Gupta, Dr. Shah.
So I just have a question regarding the images that you showed before about the second case, this kind of something going on around the strat.
Yes.
I think it was it thrombus, or was just you think plaque prolapse, or?
I think it was a plaque prolapse, because patient was not unstable, so it's patient with a stable angina, clinically silent, and I do think that it's a plaque prolapse due to a soft plaque in this lesion.
And regarding the septal, did the patient have any myocardial infarction post-procedure?
No, there was no. Maybe it was just intermittent. Okay. Because after deployment of scaffold, side branch was open. After post-dilation, it was closed. And on follow-up, it was open again. And there were no troponin release.
Let me run questions about the PSP principle. The oldest step is very important. All we agree. But how we can choose the size of scaffold? According to QCA, according to IWUS or OCT, what is the clinical practice was the most important method for measure vessel diameter and choosing the scaffold diameter.
Yeah, I think it's a very important point. And based on our absorb experience and global absorb experience, we strongly recommend reliable vessel sizing. And I personally recommend OCT as a best imaging technique for reliable sizing. And definitely in this, at least in this early stage with a new generation of scaffold, we cannot allow to have a suboptimal result. So we have to be 100% sure that we have an optimal sizing. And I do strongly recommend OCT sizing or IVUS sizing. And definitely afterwards, after proper sizing, you can upsize if there is not optimal OCT result with 0.5 millimeter larger NC balloon.
I think I will agree with you 100%. We have a very big experience with Absorb in the Middle East, especially our colleague in Dubai. When we start the program of Absorb in Saudi Arabia, we start routinely sizing with OCT. But I can assure you, if you do at least the first 15 to 20 patients using OCT, you will have more experience, then you might not use it as a routine. Some of the cath lab, they don't have OCT, especially the private hospital, they might use at least IVUS. But like only routine fluoro, it's not enough.
Yeah, definitely.
What do you think is the follow-up OCT? Because when we were told by Abbott, for example, that Absorb will disappear from the vessel in the first 2.5 years, and unfortunately, we did some OCT up to 3 years, and you still see a good amount of the scaffold. Then they changed their mind, they said up to 5 years. Do you think we will have the same problem with the mirrors?
Definitely not the same, because it is 100 micron in comparison to 156 microns. Definitely it's less material, less PLLA, and definitely it should be a shorter period. But I do not have a long-term OCT follow-up to share with you. Let's hope that after 2 years, we'll see significant amount of scaffold disappearing.
I have one remark about the size choosing, because the diameter, when we choose the for stent, for example, is media to media. This is the proper diameter. But media is always more definitely detectable after IVUS than OCT. Because media to media detect OCT worse than IVUS, because in IVUS we clearly see the media border, and media diameter is the more properly than only intima, because OCT shows the intima more properly than IVUS. And there is some maybe one on remark. I think that IVUS is always better for choosing vessel diameter than OCT.
Okay.
Because when we use OCT in diameter, we make the mistakes. Because we can not see on IVUS always media to media diameter.
Yes,
it's one remark.
Absolutely, you're right. Media to media is more reliable on IVUS, definitely. Yes.
Thank you. My name is Berlian, and I'm from Indonesia. I have one question. With this relatively short-term and limited number of participants in the Meril trial, we see a very good result. But what is, in your personal opinion, will the longer-term, more patients trial that is in the pipeline, will it disappoint us like what we have experienced with Absorb, or do you feel optimistic? Because we are sort of like, personally me, I'm in the wait and see phase for the bigger trial. Okay, thank you.
Yes, definitely. Again, let me just remind you that first in main, MERES 1 and Extent 1 are selected patients with a focal disease. So we cannot extrapolate our experience in such patient subsets on all comers, particularly in diffuse calcific disease, in complex CTO patients, even in STEMI. We do not know how it will behave, whether there will be enough scaffolding of the lesion. So far, whatever we are discussing is related to this limited plaque burden and selected patients. Let's hope in future when we will have more experience and a longer-term follow-up, particularly a longer-term OCT follow-up. With longer-term OCT follow-up, we'll learn more. First of all, as it was mentioned, whether we'll see whether resorption is more efficient in comparison to absorb, and what is the late lumen loss after 2 years or after 4 years of follow-up.
Well, one more thing. About 4 years ago, I attended like a workshop like this with Absorb, and I remember one of the speakers is from India. He was very optimistic. He put Absorb in even lesions that we could not think of. Technically, it was successful. He showed the immediate result, the stand-up position, etc. It was very good. It was 4 years ago, before the longer term trial came out. So should the question remain for me, should we adopt now this particular stent, or should we just wait a little longer for the longer term
definitely it's better to be on a safe side to wait some more follow-up. So far it looks perfect. There are no issues, but we definitely need a longer term follow-up. What was unfortunate with Absorb, I think the device was not ready for all comers. And my personal opinion was then and now is the same, that Absorb was not ready for workhorse and full plastic jacket as it used to do with some very important investigators in Europe, which implanted Absorb, 10 Absorb in one patient. So device is not ready for such scenario, even with the complex bifurcations, with the 2 balloons, kissing, crushing. So device was not ready, and particularly not ready for a diffuse and a small vessel disease.
Another comment on this would be like any new device is not for everybody. You know, we have to be selective. At the same time, we should. This applies to the operator as well. I think where a new device comes, when we have limited experience, the operator becomes equally important. You know, a center which has more experience has adjunctive therapies like the need for IVUS imaging. You know, without this, as he said, at least in the initial cases, we need to have imaging for optimal deployment of any new device or any new stent. And as experience grows, you develop sort of, we call as IVUS size, or you can then size with your eyes or with the routine QCA. But before that, you need more optimization, not only of the stent technology, but the deployment techniques as well. And one more question, what do you think is like, we talk about preparation, we talked about the sizing. How about post-dilatation, and what pressures do you recommend?
Yes, we recommend post-dilation in all cases, particularly if you're not using OCT control. If you're not using OCT control, it is much safer to perform optimal post-dilation with NC balloon. If you're using OCT, in some cases we can see that with a good lesion preparation, with a proper sizing, with high pressure deployment on 16 atmosphere, we have a perfect apposition. In that case, you do not need post-dilation. So thank you very much for now. I have been informed that Professor Santoso is ready for a live case from Jakarta, Indonesia. May we see whether we are in touch with Dr. Santoso? And Dr. Santoso is one of the leaders of MERES Extend, gave a significant contribution in enrollment of this trial.
Very interesting.
Good morning, Dr. Santoso. Can you hear us? Unfortunately, we cannot hear.
Sasko,
Yes.
when transmission is prepared, one question to you, for personal opinion. What do you think the resorption time does matter or not? It's so important when stent disappeared after 1 year, 2 years, 3 years, or 5 years. It's so important. Does matter or not? What is your personal opinion?
I think resorption is there should be some trade-off with faster resorption. Let's say with Magmaris, I have limited experience with Magmaris, with a good angiographic outcome, but we have seen several cases with collapse of the scaffold of magnesium. It means it is dissolving after 1 year, so it's losing the radial strength. So there is some trade-off with faster absorption.
And what is the optimal time? 1 year, maybe beyond 1 year?
I do not have a...
Yeah, of course.
But maybe 2 years, maybe. I'm not sure. I do not have any data to support this.
Yeah, because I always think that endothelialization process is much more important than resorption process.
Absolutely.
If endothelialization is finalized, it's absolutely safe.
Yes.
Absolutely safe. And resorption process does not matter. So
if it is faster resorption, then there is a greater risk of recoil.
I agree. Totally agree.
If you have a minute, one more question. I understand the bifurcation lesion is a contraindication for BVS, but I think you have maybe you have experience implantation BVS in bifurcation in your cath lab daily practice. Do you have any practice?
For bifurcations?
Yep.
I do not have extended experience with absorb with bifurcations, and I do believe that device is not ready currently for complex bifurcational disease. Yes.
I think one of the major problem our colleague they did see with the heavy use of absorb was one of the bifurcation. They did too many bifurcation, and unfortunately even a physician was or underwent a bifurcation absorb. He was jogging and he died suddenly. And I think since that time the operator he stopped doing any bifurcation with the absorb. And the trend was to do the main vessel absorb, and if you think the daughter cell or the side branch more than or equal to 2.5, you can go with the drug-eluting stent if it is highly indicated, otherwise just provisional stenting. And most of the problem happened with bifurcation and heavily calcified lesions. Regarding the side branch, we did see a lot of improvement on the long follow-up on the side branch. It could be due to some resorption by time. And this is one of the notification we did see with this technology. But I don't think we prefer it.
We know.
Yes.
We'll switch to Sion Hospital. Meanwhile, they get their audio system sorted out. So Sion Hospital is ready with their case.
So is there absorb is still available in Saudi Arabia? You're using?
It's available, but we are not using it.
Okay.
Since the last, trials and the follow-up of the 3 years, we stopped using it. And one of the problem you have to keep in mind, it was very expensive. Only limited countries in the Middle East use it heavily.
Okay.
The dissolve is coming, but again, it's the same concern. Dissolve, absorb, I think wait and see. This is the best approach for the time being.
And in Netherlands? Okay, so we move to Sion Hospital in Mumbai. So this setting is not a scaffold setting, I think structural setting. Okay. Not so many people in the room for a scaffold implantation.
We are on the screen.
Good morning, Dr. Sharma. Can you hear us?
Yes, I can do
Okay.
Somebody has to be at the pacemaker.
Yes, pacemaker कौन है? Yes, sir.
You have to hold it in your hand.
Pacemaker be ready.
So the command will be like this: begin pacing, and then we'll do our valve thing. And once I ask you to stop pacing, that is the time you stop pacing. So
good morning. We can hear you well. Are you hearing us?
Knob. So you go 160. When I say stop pacing, you come down to 40. So you then don't find those buttons. Yep.
Yes.
Okay. Okay. Good morning to our all the audience and our chairpersons. We are ready to relay the case here from Sion Hospital. This is the case of my valve TAVI. And if you can hear us and see us,
yes,
we'll start our case presentation.
Arvind, present.
Yes, good morning. We are seeing you and hearing you perfectly
Hello.
fine.
Good morning, everybody. Welcome all from Sion Hospital, Mumbai. Today we are doing a MyValve case. He is a 65-year-old male, known case of COPD on fluorocard 2 puffs per day, by day. He presented to us with dyspnea on exertion class 3 to 4 since 2 years. His echo was done. It was suggestive of calcific severe degenerative aortic stenosis with global hypokinesia, EF of 30 to 35%, and a mild MR. His angiography was done. It was suggestive of normal coronaries. The ECG was suggestive of LVH with multiple T-lead inversions. X-ray was suggestive of mild cardiomegaly. The aortic valve gradients were 72 by 54 millimeter of mercury, and aortic valve area by continuity equation was 0.8 centimeter square. The patient, various scores of the patients were calculated. The STS score came out to be 5.7. There were 2 major organ dysfunction, cardiac dysfunction with COPD, and patient was grade 1 frail. So based on that, we took a decision to take the patient for MyValve procedure. Thank you.
We check the orientation. This is good. Cuff is towards the ventricle.
Okay, are we ready?
So this is the orientation. So this cuff tells us this has to be towards the blue segment.
So can you explain us your approach,
okay,
your strategy?
So can you hear us and see us?
Yes, yes.
Do you want to see the mission?
We are seeing you and hearing you perfectly fine.
Go to the beginning of the case on the floor.
Scene minus. Scene plus.
So scene plus.
Yeah.
Good. Just leave it there. Okay. Can you hear us now?
Yes, yes. Are you hearing us?
But why can't we hear them? But anyway, hopefully it's a one-way transmission, but will become two-way soon. But you can see here, this is the patient in nutshell. A typical patient which we are encountering in outside in US and so, although age is different, 65-year-old, has extreme COPD and LV dysfunction, frailty, and appropriate for TAVI valve with a severe aortic stenosis. It really, he also has some mitral disease and LV dysfunction, puts him to a high risk from the TAVI procedure, but we started here this case with, as you can see here, try to get access in the common femoral by the catheter which has been advanced from the right femoral into the left iliac vessels, and you can see the vessel size is good, about 7 millimeter, and so that exactly was on the CAT scan. And plan is to open the aortic valve first with a balloon and then deploy the MyValve. So this is where next. So here, after that, you have to put out the 3 pre-closes which were done, or proglides, so that can accommodate 22 French sheath. And this is a pigtail catheter, slightly not exactly in the left, in the non-coronary sinus, in the right sinus. But you can see here, very calcific aortic valve, and there's slight regurgitation. You also see a temporary pacemaker, because pacemaker will be required during the valve deployment. We need to pace the ventricle at 140 or 150 beats per minute so that the valve does not move at the time of deployment. And after this procedure, next. So here, we did a balloon valvuloplasty. So next, you can see the balloon inflating. And usually we do about 20 or 22 millimeter. You see there is a little dent at about 2 o'clock because there is a big calcific nodule there. And that is one of the predisposing factor, not only just for the patient developing heart block, but more importantly for annulus rupture. So based on that, the sizing of the valves, and so I'll ask Dr. Ravindra to speak. And of course, we thank Dr. Mahajan to give us the chance and to relay this MyValve case from here. Dr. Mahajan, you want to say a few points?
Good morning, everybody. I think this is the first MyValve case in any teaching hospital, teaching institute, and this will open all the for the poor patients, that will be the biggest thing. So I wish best of luck for my patient, and I sincerely thanks to my head of the department, Dr. Pratap Nathani sir, who is the inspiration behind all these cases. So, and the whole team of my department.
Good.
I welcome you for this case.
Okay.
Thank you.
Tell a little more about the My Valve and your experience and what it is. Yeah.
Thank you, Dr. Mahajan. And as you all know, My Valve is first indigenous transcatheter aortic valve, and it is a privilege and proud moment for all of us to be associated with this valve. It is a balloon expandable valve. And as you know, these transcatheter valves, we don't put any sutures. So how do they stay in place? All these valves are oversized. And the oversizing is what we are aiming from 0 to 15% oversize. So all these valves are sized based on area. And area is measured by doing a CT scan. And we find out the annular plane and measure the area and the minimal and maximal diameter. So the area for this patient is 340 millimeters square. And based on the sizing chart, we selected a 23 millimeter valve, which is almost 15 to 16% oversize. And the way we will be landing is the we would be aiming at 80%, 70 to 80% aortic and 20 to 30% ventricular side. This valve also has a cuff on the inflow portion to prevent the paravalvular leaks. But important aspect in this patient, as you can see, there is a lot of mitral annular calcification. There is a calcified nodule or a chunk on the left coronary sinus. So whenever there is a heavy calcification at the level of annulus, definitely there are certain risks associated with the balloon expandable valve like annular rupture, paravalvular leak, complete heart block. So that's why the sizing becomes very important. So you have already seen we have done a BAV using a 20 mm balloon. Sometimes we can also look and appreciate the movement of the calcium which is present at the annulus. And next is we are ready with a valve.
Okay, and this is the valve. We can focus the valve now. And it's a balloon crimped. The Sapien little different. A lot of features of balloon expandable, which we have the Sapien valve in United States, and of course being done some cases in India also. But here is that it's crimped already, so you don't need to adjust. And the sheath on the groin 22 French has been has already been inserted, and we will be ready to insert the valve now. So and it's a 23 millimeter valve.
So we're taking a 23 millimeter valve, and the delivery system, there's a unique feature of a delivery system. It can be flexed almost more than 90 degrees on itself.
Yes, are you hearing us now?
You have to always check the orientation of the valve. Make sure.
Okay. So we are ready to start now. Keep going.
Fluoro. So you want to open this up, sir? Then you'll have to close again. Open, open, open all the way. Okay. So I'm going in.
Yep.
Now close. Yeah, close now. Why? Okay.
Yep.
Show us the aorta.
Show above.
You want to retract? Yep. Flex it.
Yeah. Show above now. On the top.
Arch. Show us the arch, please.
Keep advancing. Now you can see. Go above. Yeah. So I will flex it so it does not touch, does not rub against the major part of the aorta.
Show us the wire tip. Wire tip.
Now
please.
go down below. And then here you can start straightening a little bit.
Leave the pigtail, please.
Yeah.
Do you hear us?
What is the size of the valve?
The delivery.
Straighten a little bit.
Yeah.
Yeah.
23. It's
Close that. No. So we'll have to do it. Maybe we can do a more retroflexion here. This was the reason why we wanted to do a pre-dilatation. I'm going to push the wire. Push the wire.
Yeah. No.
What we do is,
no.
you want to push the wire. We do a pre-dilatation with the.
Yeah, bring that balloon again.
Yeah.
The bigger balloon.
Push the wire.
Yeah.
Secure the
Yes.
Fluoro.
Yeah, we are going to position the wire better now. Yeah. Okay, we are going to take this out.
Yeah. Coming out.
Yeah. 1 second.
Push the wire.
Get us a pigtail, please. You want to open that? You want to open? Yeah. Floor is
Pigtail back again. So what we are going to do is, we'll use same maybe 20 millimeter balloon.
Close.
Okay.
Yeah.
Okay, wire has come back out.
Give us an implant catheter.
Why did it not go?
Do you want to crimp it again?
Yes. Okay. Take it back to them.
Flora. You want to open this up? Open. Just a little. Close, close.
We need that straight
wire
wire
again.
Straight wire. Straight wire.
Fluoro, fluoro.
What wire he used? Is amplats of regular wire or something else?
Fluoro.
No, it's a super stiff.
Super stiff wire. Thank you.
Amplat super stiff. Yeah.
Yeah, let's see.
And which we made the curve
You want to open it?
to fit in. Now, but clearly that we dilated with a 20 millimeter. But now remember that because of that cusp, that calcium, we didn't go all the way. So this time now, we'll go with the extra syringe and try to open the valve a little more. You have to advance a little more, so AR2. Bring it to the, just keep it there. Good.
Okay. Leave the
Okay,
wire.
go to the RO view
Close-
now.
Close that, sir.
Good.
Get us the.
Bring the same 20 millimeter balloon.
Fluoro, please. I think we'll have to focus on this side. We'll have to position our catheter a little better.
Yeah. Huh? Yeah, keep it all the way.
Yeah, open that, please. Open the catheter. We'll use a pigtail, do you think so?
Yeah, get us another pigtail.
Pigtail, please.
Yeah. So we need a wire position better.
Close that, please. Pigtail, please. So we'll be positioning this wire with a pigtail.
Now, AR2 is easier to cross, but to manipulate the wire will be difficult. So we go with the pigtail which we had earlier.
Fluoro. So I think you'll have to be on fluoro. They'll get it there for you. Just push it down here. On the pigtail.
5 or 6 French.
Yeah, can somebody do the echo?
Pigtail.
Yeah. So, you know, the wire position is the most important thing.
And you always also have to keep seeing that there is no pericardial effusion because these wires are very traumatic for the ventricle.
Yeah. You want to open that? Just a little bit. Open? Okay.
Why patient is pulse rate 145? No pace.
No, sinus tachycardia.
It's a sinus tachycardia. Why patient develops sinus tachycardia?
Open that, please.
No. Tachycardia from the wire.
Close it, sir, please. Close.
Yeah. Good.
See the calcium now.
Yeah.
Yeah, okay.
Good. So this is now
Open
at the
that,
apex.
Open that. Yeah, you want to move the wire? So we'll go in again with the valve, with the balloon. We'll do a pre-dilatation. Close that, please. Let's have a 20 cc balloon.
Same 20?
Same 20.
Yeah.
Which balloon you gonna use? 22?
It's the same, comes with the, what's the name of this balloon?
Mammoth.
mammoth. It's a 20 millimeter.
Give him a lot of blood. You want to open that?
And we are going to put a little extra syringe, put a little extra dye in there.
Yeah. Fluoro. Okay, close it now. Close. Good.
Should I close it completely?
Yeah, close it. We'll put some extra dye in there.
Yeah. Just 1 second.
Open a little. Yeah, hold on. Give us 30 cc's of content.
Patient ready?
Now, guys, here.
Give us 40 cc. Yeah, we can put something from here. Sit all the time.
No. Where is the saline?
Yeah.
Yeah, that's
Let us just take the saline.
good. That's good. Good.
Okay.
Okay.
Somebody's on the pacer? Okay.
Yeah. Okay.
Okay.
Let's
Going
go.
in.
Yeah.
You want to push the wire a little?
I think it's gone through the pigtail. Take the pigtail out. Good.
Negative. Close it. Close that, please. Close it. Okay.
Yeah, we are good. Okay, good. That's good.
Yeah.
Go.
Begin pacing. Close it, please. Close it here, sir. Yeah. Begin pacing 140. Okay. Sene. Okay.
Good.
Deflate. Stop pacing. Stop pacing.
Yeah.
Yeah.
Good.
No, that's okay. Wire is good. Wire is good.
Right now it's good.
Okay. Yeah, that's fine. Okay, you want to open that now? So we have a... Yeah, okay. Yeah, open that, please. Okay. Close now. Close that. Close the sheath.
Yeah, this sheath required a little additional manipulation.
Yeah. Fluoro.
Good.
Fluoro. That's good. Don't worry about
Of the closing and so. Good.
Yeah.
So we are okay now.
Yeah. Let's have the valve again.
We get the valve again. Okay. Crimped is good.
Yeah. So let us go to the deployment angle. LAO 43, cranial 7. So you want to leave that? You want to leave that first? Fluoro, please.
Good.
Okay. You want to open that?
Yep.
Open. Close that again. Close partially. Let us retroflex it. Show us the arch. Wire is funny.
Keep going.
Yeah. Show us the wire tip.
Okay, let's do straight it.
Yeah. Let's get a pigtail down.
Yeah.
Maybe this case will need a more stronger wire like Lundqvist.
Now the straight.
Yeah, looks like that. Okay, we got in.
We are good.
Let us straighten here. Let's do a injection here.
Okay, injection.
Injector.
Remember, one person should be on injector, one on the pacemaker. Very important. You stay on the pacemaker.
10. Yes.
Yeah, one good.
Ready?
Yeah,
Yeah,
that's
17
good.
good.
Yeah. Hold on. Okay.
Okay.
Okay. So what we are really aiming at is we are aiming at the second row. Fluoro, please. Fluoro. Pressure on.
What about the other transducer pressure?
Pressure on. Yeah, pressure.
Fluoro.
Yeah,
Please,
yeah,
somebody
good.
be on the fluoro.
Yep.
So I think this is coaxial.
Yeah.
Right? Let us do one rapid pacing. We'll do one injection on rapid pacing. Pace at 140.
Yes. Injector ready? I'm pacing at 140.
Okay. Inject, please. Okay. Stop pacing. Pressure on. Let us review the film again. Scene minus. Please play the last angiogram. So what we are really aiming at is we are trying to aim for the second row So it's almost like 80 aortic and almost 20%
Go 2 millimeter in. Let's
just a 2 mm in. Fluoro. So we just go a little in.
Yeah.
I think that's good.
Yeah.
That's good.
You can do it again.
Yeah. Okay. Inject.
Not yet. At 180. 180.
Pace at 180. Inject. That's good. Okay. Stop pacing. Stop pacing. Pressure on. Play the previous.
Play again.
Play again. Play the previous picture.
Play the
previous picture. I think we are almost we're good there. I think we are good there. We are almost 70 to 80% aortic and 20% ventricular.
Can we confirm with the echo? That's it. We go now.
Yeah, I think we go. We leave the pigtail in place.
Okay. Yeah.
We won't remove the pigtail. We'll try to trap the pigtail here just because we'll be 100% sure where we are landing. We see that calcification on the mitral annular calcification. We'll be looking at that very carefully as we are expanding. So I think we all are good here. We begin our deployment. So fluoro. Okay.
What do you think? Do you go 1 millimeter more, or we are okay? What do you think?
We are okay.
We're okay.
Yeah.
Good.
Yeah.
Good.
Yeah.
Okay.
Okay. So who's at the pacemaker? All right.
Now we are open here, right? This one?
This is open? Yeah.
Yes, it's ready to go.
Okay. Okay. Begin pacing at 160.
We can remove the pigtail. Remove the pigtail. Don't confuse. Yeah.
Yeah. Okay. Pressure low. Inflate. Begin inflation. Inflation. Inflate. Inflate. Okay. Fully inflate. Commit. Fully inflate. Fully inflate. So, fully inflate.
Wait, more.
Okay. 1001, 1002, 1003, 4. Deflate. Deflate.
Good.
Deflate. Stop pacing now. Fluoro. Stop pacing.
Good.
All right. Show us the echo.
No, wire came out.
Wire came out.
That's okay. Leave it there.
Yeah.
Let's slow down, everybody.
Okay. Look at the echocardiogram. Let us see what do you see.
Yeah, which is good. No, it's
Can they see the echo? You want to show the echo there? Make a echo. Turn this to the echo.
Fluoro. I think we just... so let us look at the hemodynamics. The systolic blood pressure is 170. Diastolic is 93. And can you play the previous picture again? Off fluoro.
But why we cannot see the echo? What's happening with the echo?
You can see, sir.
Okay. How is the valve working?
Sir, valve is in situ, sir. You can see the valve, reflex of the valve.
I think... So you see that inflation, what is really happening, this balloon is inflating very nicely on the ends, which really anchors the valve in place. And then it inflates. Do you see any gradients? Okay. So we'll do one aortogram.
Okay.
Fluoro.
Aortogram ready?
So let us make the valve coaxial, please. Come a little caudal. Caudal.
Which we call the parallax.
Parallax.
So try to avoid.
Caudal.
Little more caudal.
Caudal.
Yeah.
Good. Nice.
Good.
Now go back cranial. Little cranial. I think that's good.
Yeah, that's good.
So, okay. All right, we'll take one aortogram.
Are we okay with the...
Yes.
You're saying?
Ready.
Good.
Okay.
Yep.
Aortogram ready?
Okay, Sene. Inject.
Inject.
So we see some AI there.
Just at the level of the annulus.
Yeah.
But the part of that is the calcium chunk on the left side. This is unusual because all the 3-4 cases we have done, there is almost no AI.
So I think this is what we have to decide. Either we do a post-dilatation Let us look at the echocardiogram.
Do detail echo.
Yeah. Let us do
If
the
there's
echo.
not a regurgitation much, we'll leave it. Because it may go up.
Yeah, I think what we see is we need to put one more valve in. Looks like this valve has moved a little up. It's ventricular. Yeah.
Let's see with the regurgitation. But diastolic is very good here.
Yeah,
I mean,
diastolic.
although we see a little more AI there.
What we do is, I think we crimp one more 23.
Hmm?
We crimp one more 23. Do we have one more 20? We have used the same delivery system. We crimp one more 23.
Yeah.
We should
There
put
is
it.
no significant AR.
Then leave it. Leave it.
You think so?
Yeah.
This is tachycardia related.
Okay. And there's no gradient? The 10?
There is no AR.
Leave it. Leave it. But don't do second.
See, now tuck. Color, tuck color.
Minimal AR, right? Okay, so I think then we complete the case. You see the last aortogram. So there is looks like the valve is just at the level of the annulus. Little bit of regurgitation, but taken this patient's overall condition, plus, go next. So I think it will be reasonable. We stop here because there is echocardiogram, there is no regurgitation, or little diastolic pressure, you can see. The diastolic is 90 plus. And there is a no, from the gradient point of view, gradient has been obliterated. Next. So with that taken all into account, I think it will be reasonable in this high risk patient that we stop and don't try to go put another valve in a valve. Because yes, if the hemodynamics or echo would have said residual aortic gradient or more aortic regurgitation, then yes, but based on this, I think the results may not be perfect, but they are about 90+%.
I think the good
Okay.
news here,
With that note,
Dr.
yeah.
Sharma,
Yeah.
I think the good news here, you don't see
Yes.
any acute ischemia on the ECG. That's
Right.
very reassuring
Yes.
to me. And maybe the echo finding, we could not see the regurg by echo. We did see some regurg with the fluoro here on the panel.
Right, exactly, yeah. But I think with that, okay, we thank everybody from Sion Hospital to Meril and of course all our participants and co-chairpersons for giving us this opportunity. And you move on to your next case of your relay from Indonesia. All right.
Yes, thank you very much.
Good. Very good.
Yeah.
Oh.
Okay, now we are back with Professor Santoso.
Let me check here.
Can you hear us now?
Ini terlalu encer. Terlalu encer.
Question? You hear us? No, you don't hear us. Good morning, colleagues. Do you hear us?
Yes.
May we see an image, and can you tell us at which stage you're?
We need to see the fluoro, please.
Who is calling?
Bersama kita, bersama kita.
Can you hear us? Hello? Can you hear us? Hello,
I can hear you very clearly.
Professor, we can hear you very clearly. I'm handing over to Dr. Teguh. Thank you very much.
Okay, thank you.
Thank you so much. Can you see us?
We can see that there is a discrete lesion in mid LAD.
Well, before I show that case, first of all, I would like to thank the organizing committee for inviting us to take part in this BRS symposium. I know that this is a very important meeting, especially now BRS is more or less in the setback phase, right? Because of the slightly higher reported TLR and scaffold thrombosis associated with the use of BRS according to absorbed studies. So thank you so much once again for giving me the honor, and it is my great pleasure to be participating in this very important meeting. Sashi specifically asked us to do two complex cases. One is especially long lesions and or bifurcation and multifacial disease, which I think according to the current knowledge we don't have enough data for that. But anyway, we have chosen two complex cases, and I will show you the first one. And before we show the case, I would like to share with you another case. This is a case example from the MIRES X10 trial, which is the first-in-man study of MIRES outside India. We contributed a few cases, and this is just to show. On the left panel, you will see the baseline. Can you see that?
Yes, yes, we can see clearly.
Yes, there is a discrete lesion in the mid LED, and in the mid portion, that is after implantations of MIRES 2.75 by 19, and on the right, at 6 months follow-up, very clear patent vessel. Beautiful result. And then, next slide. And this is, you see here, 3 panels. On the left upper panel, you will see the baseline, and the MLA shown on the right box there. Patient has fibrocalcified plaques, plenty of fibrocalcified plaque without calcifications. And then on the right, it is post-implantation of MIRES 2.75 by 19. You'll see the scaffold is well opposed to the wall, also on 3D pictures, and on the cross-sectional view. And the 6 months follow-up is shown in the lower panel. You will agree with me that there is excellent lesion coverage. If you remember the result of the MIRES 100 trial, the first in-man study done in India, presented by Ashok, the endothelial coverage is 99.1%, which is excellent. And there is also malapposition and no restenosis, of course. You see on the longitudinal view of this OCT, there is no restenosis at all at the sites where you have the scaffold. And this is a case that I would like to show. So I have a good impression on MIRES, and thereby I accept Sashi's invitation. Sashi is from Meril. Sashi's invitation to do to implant MIRES in complex cases. Any questions regarding this case? If not, then I will move to introduce my team here. Are you happy with the result?
Yes, perfect. Great result. Yes.
Okay, thank you so much. You make me happy also, because happiness is contagious, right? So first of all, I would like to introduce members of my team. On my right is Dr. Linda Lesion, very capable and skillful interventional cardiologist, and Sister Budi, head of staff nurse here, and Falin, who is responsible for OCT. Valiant. And at the back, you see Sister Yanti and Minda. And the tallest guy here is Lokesh from Meril. Okay? Okay, let me introduce you the case. Dr. Linda will introduce the case.
Okay. This is a long lesion in front bifurcation. Okay, slide. The male, 58 years old, he has a history of asymptomatic risk factor of dyslipidemia, physical examination revealing with the blood pressure 140 to 80, ECG, chest X-ray and echo was normal, CT scan with a triple vessel disease. Okay. Next. The coronary angiography was done with a left main normal, LED calcified, 75% stenosis in proximal, and third is a long segment stenosis in proximal, mid segment, and then 80% stenosis after the PL branch, and RCA diffuse calcification stenosis in the proximal segment. The treatment in clopidogrel, aspirin, rosuvastatin, and pantoprazole. This is the case in LAD and RCAs we was done 3 weeks ago in the proximal.
May I interrupt? You see that by purpose we use Meril's product. The upper panel we are using Biomimorph, which is a tapered stent, the only tapered stent in this world, and they also have the longest tapered stent in this world, 60 millimeter. With from time to time we use that, and you will agree with me that the result is perfect. Why do we use DES instead of scaffold? Because of cost consideration. Okay, Dr. Linda will continue.
Okay, slide.
And this is a target vessel.
Now the target vessel is a long lesion in proximal and mid CX involving the bifurcation of the big PL branch, posterior lateral branch. So do we have a recommendation of the use BRS in the real world? In view of the recent setback of BRS use, increased rate of TRF and scaffold thrombosis, is justifiable to use the BRS to treat such compression. In this case, with the MERS, if we still want to treat this lesion, what is the best strategy?
So I would like to have your expert opinion regarding these 3 important issues. Because nowadays we know that we have no hard data or evidence-based medicine to use BRS in real-world situations, and what we have now is data from registry studies showing indeed increased scaffold thrombosis and TLR as compared to DES, and also. If we want to treat, I would like to have your expert opinion. What is your best strategy to suggest us?
Yes,
we are
Dr.
listening.
Santoso,
Now it's your turn.
Now it's your turn.
Yes, so we have a distinguished panel with us. May we start from Dr. Babunashvili? What's your suggestion in this particular case with left circumflex after treatment of LAD and RCA?
Yeah, this is the truly very complex lesion with calcification, some calcification, and now we have not any recommendation use of BRS in such cases. But I have the one questions to you. What's the length by QCA of this lesion? First question, and the second was the reference vessel diameter in proximal and distal part.
Was there, pardon?
Was the length, total length of lesion by QCA and the reference vessel diameter in proximal and distal part of lesion, below the bifurcation, for example, and proximally, just in proximal to stenosis.
Okay. Actually, there are two imaging modalities for sizing.
Can you hear us?
Yes. There are three modalities for sizing. QCA, number one, as you suggested, and number two is OCT.
So, and my strategy in this case is that, as usual, predilation PSP principle. Because if we have the total length, for example, measured by QCA, and reference vessel diameter measured by IVUS or OCT, but I prefer the IVUS, I can predilate with NC balloon appropriate diameter, after that assess by OCT or by IVUS, and after that implant to BRS appropriate length, for example, absorb, because I have the experience with absorb only, no MERES. And with overlap too, I think it's length is maybe 6 centimeters, and 2 absorb, maybe 3 absorb is quite enough in length for full covering the length.
Do you have some issue with overlapping?
Overlapping. So all the issues with overlapping, because there's some principles. What can we optimally make the overlap with 2 BRS to absorb? So and after that, I can see what about the bifurcation, because both branches seems to me large branches, and I think it requires the good treatment for side branch. Okay. Maybe provisional stenting strategy is the optimal in this case, and 2 or 3 absorb with properly choosing the size of absorb.
And Dr. Balgit, what will be your strategy?
I think if we go to the evidence, there is no real support to use a different technology, because you already use a drug-eluting stent, and you might prefer to use a drug-eluting stent because you did it in the LAD or and RCA before. But I think it's a good chance for this new PRS to have not only head-to-head, it's vessel-to-vessel comparison, especially if this patient will go on the trial, and you are in a trial. I think, but as my colleague here said, I think the diameter, it seems to be a large diameter. You need a good matching between the vessel diameter and the stent size. The overlap issue, I'm not sure if you have a very long stent which will cover all PRS here, or we would like to see if there's any overlap to learn from you, because we are expert in the absorb overlap. Thank you.
Okay, Dr. Santoso, what is your definite strategy?
Okay. Of course, as I said, there are 3 imaging modalities to size the vessel, because sizing is very, very important if we want to implant BVS. So first of all, QCA.
Unfortunately, we are not hearing well.
We cannot hear you, doctor. Sorry.
There are 3 imaging modalities which we can use to assess the size of the vessel, and then decide what size of BVS would we use. First, QCA, as has been mentioned, and second, IVUS, and third, OCT. Of course, we have all these 3 modalities, but in our experience, OCT is the most accurate. And why? Because QCA tends to underestimate, especially if you have very diffuse disease. Sometimes it is rather difficult to define where the landing zone is. So there's a tendency for underestimation.
Professor, we are not able to hear you clearly. Probably there is some issue with mic. It's very, very low voice. If mic can readjust it, it will be much more clear. Thank you very much.
I will try to speak louder and slower. Hopefully, you can hear us. Okay? if you don't hear us, please let me know.
Okay, then we will see you, we will follow you.
Okay.
Just let us know which device you're going to implant.
If you miss my talk, please let me know. So there are 3 imaging modalities to help assess the size of the vessel: QCA, IFOS, and OCT. I think you hear this. I'm sorry, I have to speak slow. Is it? Can you hear us? I don't hear you. I don't hear you. Huh?
Try now, try.
Okay, they put the mic closer to my mouth. Can you hear us now?
Oh, it's a little bit better. Yes.
Okay, maybe you can make the loudspeaker louder over there, not here. Okay, we can hear you clearly. Okay, there are 3 imaging modalities for sizing, because sizing is very, very important, very crucial if we want to implant BRS. And one is QCA, second is IFOS, third is OCT. Of course, we have all these 3 modalities, but I don't rely too much on QCA, because with QCA, we tend to underestimate the vessel. And especially in diffuse disease, sometimes you cannot precisely define where the landing zone is, because quite often the landing zone is also involved in the disease process. That's the reason I don't prefer QCA. Second, IFOS. Why don't we use IFOS? Because IFOS tends to overestimate. So the most precise measurement can be obtained with OCT. Can you hear me?
Yes, yes, we are.
Okay, thank you so much. Now, can I speak faster now?
Okay, yes.
Okay, then I will try to speak faster. So in this particular case, the lesion is rather long, so we use OCT. We use initially after pre-dilatation of the distal lesion, we cannot get good flow, and thereby the image quality is not so good. But we already get the idea about the vessel diameter. So we use 3 millimeter balloon to dilate the vessel. And then after this, we do OCT, which we will show you later on. Now, regarding the technique, of course, if we use BVS, we need to use 2 BVS in overlapping one to each other. I will talk about this later on in the second case, which is more complex than this one. But we have measured the length of the lesion here with OCT. The length is 37. So we will be using 40 mm by 30 meters stent, which is one of the longest BRS available. And it is commercially available also in my country. So regarding the second issue of the setback on the use of BVS, they reported increased rate of scaffold thrombosis. I will show you the next slides. Next slide, Sugi. Okay. This is the latest meta-analysis published in the year of 2017, this year, compiling all the absorbed randomized clinical data. And you will appreciate here that in terms of TLF, target lesion failure, target vessel myocardial infarction, TLR, and definite and probable scaffold thrombosis significantly higher in and if we use BVS. Next. Next.
Let's try.
Next. Sugi, next slide. Okay. And this is a slide depicting scaffold thrombosis. You'll see here early, late, and very late stent thrombosis is also higher if we use BVS. The p-value reaches statistical significance. Next. Highly significant. So in order to be able to properly implant a scaffold, regardless of the type of scaffold, we have to follow these recommendations, actually proposed by Absorb. First, pre-deal. Pre-deal is very important. Second, sizing. We have to avoid a small vessel of less than 2.25. And with Absorb, of course, of more than 3.5. But I must say that yesterday I implanted a MIRES in a patient whose vessel is 4O, because with MIRES we have 4O millimeter stent. Okay, number 3 is post-deal. We need to use a high pressure balloon dilatation, and balloon to scaffold diameter ratio should be 1:1. And we should not exceed the recommended increase in the scaffold diameter as recommended by the manufacturer. So this 3 PSP is very important. Next. This is my dear interventional cardiologist. Just in March this year, the FDA recommends that healthcare providers can still use BVS, but we should follow the target heart vessel selections and optimal device implantation. So I would like to stress here the importance of PSP, especially if we are dealing with complex lesions. And again, I would like to stress here the importance of using compliance of the patients to dual antiplatelet medications, because the scaffold will be absorbed after 2 years. Next. Again here to show that if we comply to PSP, you see here that in the early experience depicted by the red line, thrombosis thrombotic complications is much higher as compared to if we follow the PSP protocol. This is in 4 cities in Europe. Next. And this is the subgroup analysis of the GHOST-U PSP analysis. This is a European study. You see here, if the operators comply to the PSP, the green bars, you see that the POSI and all revascularizations, DOSI, and TLR, even scaffold thrombosis, is significantly less at 1 year. So we have to comply PSP very accurately. Next. And this is the full Absorb analysis from 1 year to 3 years. Absorb Extend, Absorb 2, Absorb Japan, China, and Absorb 3. On the green bars, you see the non-PSP groups, and PSP is indicated by the yellow bar. And you'll see here, if you are in the yellow bar, you have indeed lower target lesion failure up to 1 year, up to 3 years, and even lower scaffold thrombosis up to 3 years. So again, stressing the importance of PSP, especially in complex cases. In Absorb study, all the cases are simple cases. Next. So this is even more critical if we are dealing with complex cases. We also have to acknowledge that different lesion subsets may need different and specific technique. Next. Just to show how often PSP is used in these important trials, overall only 9%. So no wonder we can see that the scaffold thrombosis and also TLF is higher. Next. So this is the official advisory from the company. Effective from March this year, this device will only be available for use in clinical registry setting on until summer next year. So sites not enrolling cases in a study will not receive shipments. So see, they are moving back, one step back. Next. This is a European recommendation on the use of BVS. I don't want to go into detail, but recommendations, back, jangan ini dulu. Recommendations, if we should start with simple case. If we have enough experience, then we may progress to treat long lesion, as in this case, bifurcations, ideally simple bifurcation case, as in this particular case. And then this is the following is Asian recommendations. Next. But this is published in the year of 2015 and 16. Almost the same as European counterparts, beginning with simple lesions and then move to long diffuse lesions and simple bifurcations among others, like in our patients. Next. So we'll show you what we have done so far, because we have been waiting so long. So I'm so sorry. We have started the patients. May we begin with the very first slide, very first video. No. The video, the angiogram. Angiogram, please. Yes. No. The first one. Nomor 1. Okay. This is LAO projection. I think you'll agree with me that the result of biomime implantations in the proximal and mid LED is perfect. Okay, you will appreciate also the lesions in the circ, ending at the bifurcation site. Next. Result in the LED is perfect. Next. Result in the LED is perfect. Next. Now you will see in the RAO caudal view, the lesions, the long lesions, extending from the proximal circ to the mid segment, involving the bifurcations. And in my opinion, it is better to salvage the posterolateral branch rather than the distal LCX. So my plan is to fix the lesions from the proximal circ to the mid segment, crossing over the distal circ. Next. Viewed in caudal view. Next. So we did pre-dill, and we used 2 wires to protect the distal circ. Next. So after this is 2.5 millimeter balloon. We use OCT, but the image quality is not that good. So probably because the lesion is distal in locations, and also there is still a significant narrowing, so the flow is not perfect. So, but we have already the idea about the size of the vessel. Again, sizing is very important. It is 3O. We choose 3O. Then, next. Next. We use 3O millimeter balloon. Next. This is OCT. I will show you the OCT later on after this. Next. Of course, we use dissection. So, I need to fix the patients rather fast, because patient is experiencing angina. Now under treatment, and hemodynamically is very stable. Blood pressure is 160/80, and there's no ECG changes. Palin will explain to you the OCT findings. Palin?
Morning, sorry.
The last one, Palin.
Hi. Can everybody hear me? Hello?
Yes, we are hearing you.
Yeah, hello. I'm here to help you to do the interpretation and also the calculations of the OCT finding
Can you
of
make
what
the
we have seen. Over here, we have the L mode and also the longitudinal mode.
There is no dropout here.
Yeah, sorry.
I want to avoid the dropout. Yeah.
Okay. So if you can see over here, we have a lumen profile calculations that they automatically calculate what is the minimum luminal area over here. As you can see, the disease is actually progressing from here to the proximal. I will show you slowly from the distal end. And from the 3D, this is the bifurcation, single wire towards the cert. And over here, from the OM to the cert, okay? And here will be the cert. The distal calculation is a 3O vessel, healthy vessel, and we can see the media. As we move forward towards proximal, this vessel consists of a lot of high lipid and a little bit of embedded calcifications. This is after the post-dilatation of a 3O. As you can see from angiographically, there's dissection, and from OCT also we can see the dissection. And fibrous plaque very heavy. And here's the dissection at the 3 o'clock, 4 o'clock, and very heavy lipid plaque. We have calculated this area. The length is 37. As you can see, we are moving towards proximally. Yeah. Prof. Teguh have actually prepared the lesions very well, and I think now he's going to progress to do the implantation. Let me allow to show the fly-through from internal side. Here's a single wire from the calculations. As we move towards proximal, and this is the bifurcation site that's coming towards proximally. Is my explanation clear? Is there any question so far?
So, Dr. Santoso, your intention is to do provisional stenting toward obtuse marginal, right?
Correct, correct. Do you agree with my strategy, or you have any other idea?
Yeah, it seems a reasonable strategy, yes.
And thank you so much for your encouragement. If we follow the recommendations of the European Bifurcation Club, EBC Club, last year, if we use BVS, the recommendation is, if possible, try to use provisional stenting strategy. This is the best for BVS. So in this particular case, I use 40 millimeter by 3.0 meters, and I will show you.
May I ask you one question, Professor? One question, please. What's the length of lesion according to OCT?
What's the
length of lesion according to OCT measure?
37.
The length.
Right?
The length.
The length of lesion.
Length of lesion 37. 37. 37. So we are using 40, and you'll see here how trackable or it's not trackable, because this is a long. I hope that I can advance it. You see? You have to cross all your fingers. Okay? If not, then I will make another dilatation.
So it's a pretty angulated and a diffused long lesion, definitely.
Yes. There is also patchy calcifications, but not much. We have induced dissection. But we are happy with the dissection because that means that we already have a good platform for our BBS. So dissection is quite acceptable. I think we need to do more pre-deal because we cannot advance it. Okay. We have pre-deal with 3O balloon, but we cannot advance that. Result is actually excellent. I mean, we have get rid of all the waste. We will do more pre-dilatation.
And would you consider a guider extension in this case, Dr. Santoso? Kind of guideliner or guidezilla?
Yes, there is also an option, of course. There is, of course, an option, guidezilla. Test.
Budget.
Okay, read it like
Professor, one question. Which wire you use now?
And then?
Wire.
Wire. What wire?
Yes, wire. Coronary wire. Which one?
Run through and Sion. Run through from Terumo and Sion from Asahi.
So it is the same balloon, 3O?
This is 3O balloon, yes. Yep. Berapa? Rated berapa? Rated berapa? Berapa? Itu berapa? 6. Oke, 14. Usually, I try to deep sheet my guiding.
Professor, what is the size of balloon? 3.0?
3.0, yes. This is according to the QCA. Okay, test. The deflate. Test. Okay. Yep. Very good. So I try to deep sheet my guiding, see? Okay? Deflate. Now I will reintroduce the scaffold. Tolong ini hubnya. Tolong hubnya. Okay, scaffold.
So, Dr. Gupta, what will be your suggestion in this how to overcome this issue?
Your suggestion? My suggestion in
Dr. Shah, from a panel.
I think it's a fairly long lesion, and Dr. Santoso has been fairly ambitious, taking a very long BVS. But I think with this pre-dilatation, hopefully, we should get through. There was this is a bifurcation. There was a lesion at the ostium of the circ also. So possibly, I don't know whether he's stenting from the circ into the OM or into the circ and gelling the OM. Possibly, standing into the circ because there was some osteal lesion there would possibly be more desirable. So with this pre-dilatation, if it doesn't go, then we have maybe a couple of choice. One, we could use 2 BRS instead of 1 and overlap. That would be much easier to go. And this is a circumflex. Getting a 40 BRS into the circumflex is never going to be easy. Or we could use some device like a guideliner or something to get this BRS in.
Actually, we may be facing the same issue even with a long drug-eluting stent, metallic
Exactly,
stent.
especially in this
so this angulated, diffuse lesion, my personal approach will be directly to start with guider extension, definitely.
I have properly dilated the lesion. until I can get rid of all the waste. Tolong please, tolong dicek. Hey, test. Now the option is to use.
I think it's a guideline going in.
Guidezilla or use Guidezilla or use other technique.
So this Meris is compatible with the Guidezilla.
Yes, it's comparable.
Yeah, this is 6 French. Is it compatible with the
Guidezilla? I will use Guidezilla. Coba dulu ininya bisa masuk nggak? Guidezilla 7.
Guidezilla 7.
The another option is to use the more stronger wire, for example, Grand Slam.
Yes, more extra supportive wire, definitely.
Masuk nggak? Coba buka aja satu. Masuk nggak? Coba dicek dulu.
You know, sometimes we are underestimating the angulation from circumflex, left main circumflex.
Yes.
How much time you can leave the mirrors outside the body before you re-implant? Do you have any limitation, like technology-wise? Because other company they recommend within 15 minutes.
I'm not aware of any particular time frame in regarding this this frame.
Coba aja dulu, masukin dulu coba. Masuk nggak? Coba dulu. Jangan di close up tangan saya, jangan dulu. Jangan di close up tangan saya. Jangan di close up tangan. Oke, masukin. Coba masukin. Coba masukin.
So, Dr. Santoso, you choose the most difficult lesion in this multivessel disease patient for a scaffold. You treated the easiest with metallic stent and challenge the most difficult one with scaffold, right?
Yes. Ke yang mana? Ke yang hijau ya? Salah.
Yes, Sasko, one issue is that we discussed it here when we remove the BRS after unsuccessful attempting. So the PLLA maybe change the properties.
Yes.
Absorb the
it
water
makes sense
becomes
if
the more bigger profile and maybe they change another device.
Yes, it makes sense if it is longer than several minutes than to change the device. It makes sense.
If we use BVS, normally we try to introduce the BVS outside the body first, just to check whether it can go through. Saya minta miras baru lagi. Saya minta miras yang baru dah. Can I have a new miras? If we use BVS, if we use Guidezilla, in my practice we normally try to introduce this outside the body because sometimes the device will get swollen outside. So it may not necessarily be that easy to introduce to the guide sila. Okay. Lah, keluarin lagi. Yang itu dimasukin bareng. Mana. Oke, mana itunya kayak silanya mana? Bukan. Ini kayak sila. Ini kayak sila. Oh, I lose my wire position. I'm so sorry. I lose my wire position outside. No worries, no worries. We'll fix it. We will fix it. No worries. Mana yang itu? Lepas.
Lepas nada.
Mana yang itu? Yang itu. We will fix that. Or we will lose the guiding catheter position also. Okay, things happen. No worries. Okay, mendadak rumah. Enggak PA biasa. You see, I think having this kind of problem is good for you, right? This is kind of educational. To find how difficult it is to, sometimes we get difficulty to introduce a long scaffold. Scaffold is slightly thicker than stent, of course.
Saya tarik dulu tuh.
Tes.
Ya, saya tarik dikit ya.
Tes.
Saya tarik dikit. Oke.
Okay, very good. We'll start from the beginning. I'll try to finish as fast as possible. Siapin wire baru. How many minutes do I still have time?
We have 12 minutes so far.
Oh, plenty of time?
Yes.
Okay, good. This wire is not steerable anymore. This is an old wire, mental wire. Test. Okay.
So maybe if you're using guide liner, one wire will be enough.
Yes, but I will use 2 wires. Okay.
Keep it there as a body wire. It will help. Believe me.
Okay, I need more bend, but in order to save time, I will introduce the guide wire because otherwise the scaffold will get swollen.
Swollen. Maybe it's swollen already.
Ya, tadi mana kait wire-nya?
Wire.
Kait silanya.
Kait silanya mana?
Kait sila sama scaffoldnya. Saya nggak mau wire lagi.
Kait sila.
So I don't introduce the second wire just to save time because
Okay.
I don't want
Ini
to
apa?
get the
Gajila.
scaffold. Gajila plus scaffoldnya harus masuk di dalam sini.
Scaffold.
So it might definitely shorten up resorption time afterwards. Less than 2 years.
Oke, nanti masukinnya bareng.
No, CT.
Kait sila sama ini bareng.
Apanya belum?
Kait sila
Ini
sama
gajila.
scaffold. Ini kait sila.
And Dr. Balgit, is MERES available in Saudi Arabia?
I don't think so. But it will be there soon.
Okay.
Belum keluar. Iya, iya.
Pegang dulu, pegang dulu.
Yes.
Ya, pegang wire.
Yes.
Pegang wire.
Yes.
Oh yeah.
Sasko, may I
Yes.
ask you questions to you personally? When you use the Gujrat technique for bifurcation, such as in this case, I think there is maybe risk when we try to remove the Gujrat wire for BRS, for example, because there's not metal. It's the most soft construction. Is there risk to damage to
I think there is no significant risk because there is no significant bifurcational disease. So side branch is not a significant disease. So I do not, and there is, as far as I can see from this image, no heavy calcified bifurcation. If it is heavily calcified with a significant side branch, then it might become an issue.
That's. Okay, biasa. Biasa.
The catheter becoming soft.
Biasa. Test. Dikeluarin. Saya minta wire satu. Saya minta balon satu untuk LED. Pegang kodel. Pegang kodel. Tes. Saya minta pegang kranial dulu. Cepetan dikit dong, Dinda. Oke, saya minta balon 36. Oke, saya minta balon wire lagi. Ini tolong dilepas dari situ ya. New wire nggak ada, Bud? Ya. So I introduce one wire in the LED to fix the guiding catheter. Test the kit. Okay, I will leave the distal L6 unprotected because I need to act fast. Saya minta bola 3 untuk kali ini.
So, Dr. Santoso, what is your default access in your practice?
Default access for?
Yes, for a PCI. It's a right radial?
Yes, usually in 95% of the cases we use transradial approach, especially only if we are dealing with CTO, then we use bifemoral.
Okay.
Nggak usah, langsung BBS. So as I need to act fast, I will use the anchor technique to help introduce my BBS. Hopefully this will work.
So this is a 3.0 balloon in LED?
Correct. Blue. Okay, blue. Okay. So it's faster because I don't want my BBS to get too much of swelling. Okay. Now I need to go more proximal. Look at there. Test. Test. You see, one 7 French guider can accommodate one balloon and one scaffold, but not 2 scaffolds. So you need to use, for example, kissing. You want to apply kissing full.
So it was a very good demonstration that you can use with a 6 French guiding, one balloon and scaffold at the same time. So it's a clear demonstration. It's a very low profile device.
I think one word of caution here, this device is a mixed cell pattern. There are some closed cells at the edges. So I think when we're dealing with a bifurcation like this, at least the distal 3-4 millimeters should be into the vessel, so that in case you want to recross, it's not the closed cell design which is there at the ostium of the side branch. I think we need to remember while using a Biomine or a Meris.
It's a very good point, yeah. So if you consider recrossing and doing some side branch dilation, of course it should be preferentially through the flexible open cell.
So the distal should be a little distal to the branch.
Sampai 10, tunggu sampai 10, sampai kalau udah 4. Terus, udah naik lagi. Kalau udah hitungan 5, itu berapa? 3, oke. Naik lagi, nanti dulu.
So for a scaffold, let me just remind you that we have 3 markers proximal and 3 distal. So it's it provides you very good orientation.
I think the visualization of this markers is much better than the absorb, because you have 3 markers there. It's much easy to locate them.
Terus, hitungan 5 ya. Oke, nominal berapa? 6 kan? Hah? So we increase the pressure very, very slowly as recommended by the manufacturer. We'll go to 9, which is the okay, which is the nominal pressure. Okay, deflate. There is a minor ST elevation, the lateral lead, but now resolving. Blood pressure is okay.
What the final pressure?
Blood pressure is 164/74. How many minutes do I still have time?
Okay, just take your time. We have a few minutes more just to see the final result.
Okay, I will post that deal just to save time. It's not bad,
Oh,
right?
it looks very good, yes.
Okay, saya minta 3 seperempat.
So what's your intention now? To directly post-dilate or first do OCT?
Yes, we need to do post dilatation. Of course, we can do OCT, but I don't want the patients to consume a lot of contrast medium. So I would rather do post-dil and then assess the vessel after post-dil. And then after, if the result is still suboptimal, then I'll do another post-dil.
Okay, perfect.
But angiographically, the result is quite acceptable.
It's an excellent result, excellent angiographic result, yes.
We'll be using a 3.25 millimeter balloon. Tes, saya nggak mau kena di center. Tes. Ratingnya berapa? Ratingnya berapa?
The balloon size is 3.5
Nominal 12.
or 3.0.
Berapa? 3.25. Hah? Hah?
So with these 3 markers...
The nominal pressure is, yes, you will see that, can you see the 3 markers?
Yes, it's very easy to position balloon.
Yes, I intentionally inflate this balloon above the bifurcation. I will do a small shot here, okay? Above the bifurcation.
Yes.
Okay.
Kind of proximal optimization.
12. 14 berapa? Anda langsung sebut. 14 berapa? Anda berdiri dekat saya. Hah? Pelan. Ini tiap 4 menit. Tiap hitungan 5 naik 1. So So even though we use high pressure balloon dilatation, quarter size bigger, we inflate the balloon very slowly. So initially we can do it fast until the diameter that we reach after implantations, and then we go slowly.
And what's your final pressure with this balloon?
14 berapa? Berapa? Okay, deflate. This is 14 at deflate. At 14 atmosphere, the diameter is 3.3. Kalau 3,5 berapa? Hai. Oke, sini. Kita nominal berapa? Yang 3. 10 berapa? 10. Okay, 10. So we can go fast until 3 mm. Then we increase the pressure slowly. 1 atmosphere after 5 seconds. Terus sampai tadi berapa? Kita sampai berapa? 14. Hah? Sama 14. 13. 14. Okay. Okay, deflate. Now I will do angio and then OCT.
Very good result. Yes, perfect.
Thank you. But we need to show this on OCT. One interesting thing with MIRAS as compared to BBS is that because the scaffold is thinner, 100 micron as compared to 150 microns, quite often after post-deal, we will see that the struts are more embedded to the wall. By having embedded struts, we will decrease the possibility of the patients to develop scaffold thrombosis. Oke, jangan di film waktu saya bikin OCT. Jangan sekali-kali di film. Jangan di film ke saya. Film ke tempat lain silakan. Ini saran, ini saran. Film ke tempat OCT boleh. So, is it clear? Ini kurang masuk. Ini jangan ditarik ke belakang. Okay. We have to make sure that the OCT covers the stent, the scaffold, see? Okay. Okay, jangan di close up ke saya nggak mau. Okay, ready? Okay. Yeah, this held a second. Can you make the vessel long? I don't want to see the dropouts. Move. So, no, not a, okay, that's perfect. Okay, you go from distal. Can you see the OCT?
Yes, yes, we can see it.
Okay, let's go from the distal. You see, this is sometimes a problem with BVS. We have, if there is a slight discrepancy between the proximal and distal part, this is dissection, distal dissection. It's not flow limiting, but we usually use, see, there is distal dissection. Even though the scaffold is well opposed to the wall. Can you see? Can you see the OCT tracings?
Yes, yes, we can see it.
Okay, okay. And this is after 3.5 millimeter balloon dilatations. And even though I intentionally have avoided the distal end of the scaffold, so still I induce dissection because the vessel is diseased all over. In some area there is still a malposition, but it is minor.
Yes.
Again, malposition here, but I think we can accept this. This is just in 3 or 4 frames only. So I would like to have your suggestion. Should we treat the distal dissection and should we treat the malposition? The minor malposition, especially in the proximal end of the segment.
So can we see a final angio again? Final angio?
You are the... Okay, film yang terakhir. Film yang terakhir. There is no flow limiting dissection.
Yes. And at this part of dissection, scaffold is perfectly opposed to the vessel wall.
Yes, I will show you the.
You know, with the OCT, with this new technology, we could see more details of the vessel, which we never saw before with the regular angiogram. And that's why you might not need to treat every spot you see with the OCT, especially if the patient stable, no chest pain, no ECG changes, and the fluoro okay. But again, there is some grading for the dissection by OCT.
I don't think that this is induced by OCT. It's very rare in my humble experience. The problem with OCT is that if we place the scaffold in angulated segment or in previously calcified segment or in overlapping, we use overlapping scaffold. Sometimes we encounter problem, but of course we should not push too much. And quite often this can be solved by using a body wire technique. But we never push our OCT too forcefully in order to avoid dissection, or most importantly, in order to avoid damage to the scaffold itself. So I don't think that this is induced by OCT. But again, I want to ask your expert opinion. Should we fix this distal dissection or not?
Yes, may we start with first with the panel? What's your suggestion?
And if yes, do we have to use scaffold or DES?
Maybe I'm still the situation. I don't need. We don't need any devices because the flow is TIMI free, and not chest pain. You say no EKG is ischemia, but my opinion, I'm still there.
Okay. Will somebody from the panel recommend additional stenting or scaffolding?
So I think it's this situation needs the additional stents, maybe short metallic stent, because now the flow is good. The brisk flow, symmetry, and no ECG changes. But after removal, the wire, maybe subintimal hematoma will grow and compromise the lumen. We don't know, because I don't know what about the dissection. How complicated is this dissection? Because some haziness and angiography we can see, and some bended segment, and we don't know what about the after 2 hours, maybe 3 and 4 hours. What is the final result after this dissection? Now, at this picture of angio, finally flow is good, symmetry, and maybe finished procedure. But we don't
if we were not doing OCT, then we will immediately remove everything.
Yeah. Okay, may I give you my opinion?
Okay.
Very short metallic stent to full cover the dissected segment.
May I give you my opinion?
Yes.
Before I, because we know that scaffold, not like DES, we have to be very careful. We have suboptimal result with scaffold implantations, because the scaffold is thicker. So if we have malposition, untreated dissection, or we have fracture, for example, we need to treat that. We have to be more aggressive as compared to DES. But before we decide whether we put another stent or not, I would like Palin to help analyze the severity of this dissection, and then we can make our decision based on the OCT.
Okay.
Palin, please, Palin.
But according to the angio picture, this is the dissection, uncomplicated dissection, type maybe AB, not complicated dissection.
This is not complicated dissection, but BVS is not like the...
But dissected area or the OCT picture seems to be quite big, so quite large.
Yeah, it's more than 30%.
Yeah, more than 30%.
Wait, speak.
And maybe needs the additional stent.
Afternoon.
Can you hear
Hi.
Palin? Palin
Could you measure the
explain the
dissection
OCT.
area? Could you measure
Okay,
dissection?
Okay,
Okay.
Firstly, good afternoon, everybody. So what we have done is we have done the calculations of the length of the dissection from the distal to the distal stent. Okay, we have found that it's only about 3.4 mm square. According to one of the Columbia University for dissection to treat or not to treat, if not we will be chasing after the dissection all the way. First criteria is the TIMI flow must be good. And over here from the angiographically we can see that the TIMI flow is actually fairly well. The second dissection criteria is it cannot be more than 3 mm and all the way to 60-degree dissected. So from here, from the distal, we can see it's not 60-degree, but moving forward closer towards the stent, only is actually more than 60-degree. So they have to reach 3 criteria in order to treat the distal dissection. So far over here I've seen...
So you want to treat or not to treat?
Maybe my suggestion would be maybe we up with the balloon for a while first. We maybe stick back on the DED.
Okay, suggestion of Palin is to try balloon and then see the result. And my bias is to implant a stent, another stent. Because if the distance, the dissection is deep, and if the distance encompasses, as Palin said, more than 60%, but another expert advises more than a quarter of the quadrant, then and the distance is more than 250 microns. Can you measure it? Then we need to fix that. Okay. course, there is no international consensus on this. So this is just a biased attitude. See here, this is a deep dissection, so we need to fix this. So I was inclined to use another stent, and probably, can you measure? This is a 3.0 stent, right?
Yeah. Sasko?
Yes.
May I have a small comment?
Yes, yes.
I would like to give a different interpretation of these images, if I can. And I think this is, definitely there is a dissection, but this is not a dissection, it's a subintimal hematoma because of the extensive predilatation that has been done and because of the delay between the predilatation and putting the stent. So what happened, I think, is that the hematoma of the dissection of the whole vessel, they were squeezed distally, and this is an already closed dissection. So what we see is an hematoma, but we never see a real flap.
Yes.
So the dissection per se probably is sealed. Yes. So putting an extra stent doesn't really add a lot. What would be nice to confirm my theory would be to repeat the OCT and see whether the dissection, let's say the hematoma starts to clot. And if you see that the lucency changes, then it's an indirect confirmation that is starts to become thrombotic. And then you can avoid the stent.
Yeah.
But okay, it's my personal...
yeah, because in this situation, additional stenting will not solve this issue.
You let the hematoma migrate
go
even
more
further.
distally, yes.
Yeah.
It makes sense, it looks very deep. And does not correspond at all with the Timmy flow. So there is no, yes, absolutely. No flap.
You don't see the edge.
And probably it will thrombose by itself.
Of course, I respect all your opinion, highly respect, but we decided to put a stent. If you carefully look at the angio, there is some lucency there. Okay, so I would feel more comfortable to implant a DES, a short DES there. Taking care to implant the distal end of the stent, distal to the hematoma, distal to the dissection, in order to prevent propagation of the hematoma distally.
You went to 325, right? You went use the model of 325. No.
No worries, no worries. Take care. How many minutes do you still have time?
So what you decided to put another stent, metallic or scaffold, distally?
Metallic. I have to use a metallic stent.
So Dr. Santoso, may we suggest you that you continue in PCU work? We have a lecture from Dr. Onuma from Netherlands. So he will discuss about OCT in scaffold, and then we can come back to you and you will explain what you have done.
Okay, go ahead, please.
Okay, okay, thank you.
Share
okay,
the
thank you. Yes, now we can connect with Dr. Yoshinobu Onuma with a live lecture about OCT characteristics of BRS.
Hello. Disconnect हो रहा है. I didn't do that.
The person whom you're trying to reach is currently...
Hello. Hello. Hello.
डायरेक्ट ऊपर છે.
So while we are setting this connection, maybe we can have just a 5 minutes short break and then reconvene it in 5 minutes.
Hello.
Hello. Hello.
Hello. Good afternoon.
Hello. Yes. Connect. हो गया आ गया. Yes.
Dr. Yoshi, we have given a 5-minute tea break. So as we know, you are live now, but we'll meet in next 5 minutes. એમનો અવાજ નથી આવતો ને? એમનો અવાજ આવવા દે. Dr. Yoshi, can you hear me?
I can hear very clearly. Can you hear me or?
Yeah, I can hear you. We have a 5 minutes tea break here. So we'll stay connected, we'll stay online, and then we'll meet again in next 5 minutes.
Okay, no problem. Yeah.
I can see your screen as well. Share kar do.
Yeah.
Screen share kar do. So your screen is on.
So how was the live case?
Live case of my valve, it was a 5th case and it went absolutely fantastic. And we had a very complex case from Professor Santoso. And he is still doing a case, but we'll connect him again after your lecture.
Okay, yeah, then I have to speed up probably. I think.
No, we are very keen to learn the OCT from your end, so we request you to take your time. And then professor is recording the case, so he can always show us the case retrospectively.
Okay, yeah, that's fine. So how many people are there?
We have a full pack house here, capacity of 120 delegates. We put up some extra chairs as well, so I'm expecting somewhere around 140, 150.
Okay, that's a lot. That's a really a big auditorium.
Yes, I have. Yes, we have disconnected. Just talk to Naim sir.
Hey Suji, how are you?
Hello, can you hear me, or is the line still connected?
No, it's starting in next 2-3 minutes, and it will take around 15 minutes more from that.
So is this session will be online on YouTube or?
On YouTube.
Okay, I don't know. I prefer not to be on YouTube, but can you make it not online for my talk, or?
There will be a screen of Meril. Welcome to Meril on YouTube right now.
Okay, okay. Yeah, then that's, yeah, just keep it like that
As soon
for
as
my talk.
we give a live, then it will come on YouTube.
Okay. Yeah.
Right
but
now, audio is coming, maybe.
Oh, is that remaining on YouTube? You know.
It will remain.
Okay, I prefer not to be on YouTube. Can you make it? Because I didn't know that it is on YouTube, so it's not big deal, but.
Yes, it will be on YouTube. नहीं फुल स्क्रीन मोड पे डालूं क्या उसको बोलूं क्या आपका प्रेजेंटेशन मैडम है ना लेडीज है नहीं
Yeah, but I think
you can start your presentation.
Okay, okay, okay.
Keep on the full screen.
Yeah.
Presentation mode.
I hope I.
It will take like 1 minute, only 1 minute.
Yeah,
everyone is
because,
coming.
I don't know if you understand me, but I'm not consenting on YouTube, so I prefer not to be on YouTube. So if you can just blind things during my talk, it would be appreciated. But if it's too late, it's okay. But
sure, we will do the needful for YouTube.
Yeah, okay.
So, I think we are ready with the lecture. So, we'll proceed.
Yeah.
I'll hand it.
Yes, so
Professor Kedev is taking over the session.
Okay.
Dr. Onuma, are you hearing us here?
Yes, yeah, I can clearly hear you. So.
Okay. Okay, so we can see your screen as well.
That's good.
So it's very good continuation from a live case from Professor Santoso, because we had some OCT issues up BRS. So it will be very interesting to see your experience with OCT after BRS.
Okay, thank you for introduction. So actually my talk is about OCT characteristic of bioresorbable scaffold, what we have learned. So this slide just to show the concept of bioresorbable scaffold. So usually the coronary artery sclerosis start as intimal thickening, becoming a pathological intimal thickening and fibrotic atheroma. And up to the 40% of positive remodeling, the lumen will not be narrowed because of the compensation of the Gragov phenomenon. But at certain point, the expansive remodeling is not really compensating the lumen reduction, so the lumen is getting narrowed. And then at that time, we will implant a stent or a scaffold. But if you implant the bioresorbable scaffold, it will becomes disappeared after a certain moment. So the scaffold provides a temporary mechanical support and disappears. So lumen enlargement and plaque regression might be observed at a later follow-up. This is a picture from the ABSORB trial cohort A, and baseline is this strut and 6 months and 2 years. So in this device, you could see that at 6 months, there was some corrugated appearance of the lumen, but at the 2 years, you don't see the strut. There's some remnants here and there, but mostly you cannot recognize strut, and lumen looks like larger than the previous follow-up timing. So this is the 5 CE marked bioresorbable scaffold available in Europe in July this year. So there was 3 PLLA scaffold, absorb, dissolve, ART, and also there was phantom scaffold using tyrosine polycarbonate, and recently also the magnesium scaffold got CE mark last year. So you can see that there was a different type of bioresorption profile. For example, absorb has molecular weight loss of approximately 3 years. Dissolve has 1 year. ART has a little bit faster. Phantom has approximately 1 year or a little bit more. Magmaris, we don't know the exact molecular weight loss, but probably we will have a different mechanism of bioresorption. So each product has a slightly different bioresorption profile. And for the next couple of slides, I'm talking about the absorb scaffold because it is one of the first products which was introduced in the market of Europe, and we have really the a lot of data on OCT with this technology. So basically the bioresorption process of the PLLA scaffold is the hydrolysis. So you can really see that the PLLA is cleaved by the hydrolysis. Molecular weight goes down and eventually it goes to the Krebs cycle. And the final product of this bioresorbable scaffold is CO2 and H2O, which will be excreted from the kidney or the lung. And this is the just a magnification of the previous figures. The mass loss takes approximately 3 years. So the molecular loss starts immediately after the device touch with the blood, which is a water, and then goes down very quickly, but eventually the complete bioresorption takes more than 3 years. So the other point is that for this kind of the device, PLLA is the radiolucent, so you cannot really recognize strut itself, but you can recognize the position of the scaffold by the 2 metallic markers, which was positioned in the both end of the device. So quickly, I'd like to summarize the long-term effect of this kind of device in the preclinical study and first-in-man study. So in this series with Professor Virmani, we studied the comparison of the histology, OCT, IVAS, and IVAS echogenicity of the absorbed scaffold. So you could see that at histology, there was some change of the scaffold, but you can still see the remnant of the strut up to the 3 years. And that is similar for the OCT. You can recognize the strut as black box from baseline up to 3 years. But if you look at the IVAS, initially the strut looks like white, which is recognized as green in this IVAS or echogenicity, but gradually it goes down up to 3 years because the IVAS echogenicity is basically reflecting on the molecular weight loss, which starts immediately after the implantation. But OCT is reflecting more for the integration process which occurs after the bioresorption. So up to 3 years you can see the strut, but in the polymer point of view, the polymer is already gone up 3 years and it was replaced by some protographic provisional matrix, and after the 42 months, 4 years, I think it has better appearance, because on histology it also really the homogeneous the other part of the cannot really recognize on histology as well as OCT. Because in the IVUS, and the OCT change really occurs in the later time point more than device. So this is the IVUS trying to show the correlation between this IVUS echogenicity and molecular was the but from the third month to finish in OCT, the red is the orange is ID on so study in the on this side of the existing behind this becoming within 2 effects we said there was a and so the coincide decrease from 4 to 5 years. So if you can see the minimum area on and the minimum area sometimes loss space from 1 to 5 years. So this is the OCT findings of this first cohort. So we see that the minimum area is being those is very stable. There was some degrees, but 4 to 5 years. There was some down adaptation of the fire such kind of in this case, like later in my model, the baselines with E to 5 for 5 years follow-up, this kind of the expansion was correct by the nature of our and we can see this side was just very little yellow, but basically it is light blue which represents the physiological this one. If you waited 5 years, this disturbance shear stress becomes corrected. So this is also an example. You see that blue dark shear stress, which means that restoration of the flow and some correlated